When a patient's hemoglobin level drops to 5.6 grams per deciliter, their body enters a state of severe crisis. At this concentration, the blood physically lacks the capacity to carry enough oxygen, meaning the brain, heart, and kidneys are actively starving. A mild iron deficiency might be solved by writing a prescription for iron tablets and sending the patient home. But tablets take weeks to absorb. At a 5.6 hemoglobin level, the patient's vital organs do not have weeks. The attending physician faces an immediate two-part problem. They have to uncover exactly what biological failure caused the blood count to crash, and they have to figure out exactly how many minutes they have to intervene. This flowchart maps out the clinical triage process used to solve that problem. It splits the doctor's focus down two parallel paths: analyzing the complete blood count or CBC report to find the cause, and evaluating the physical patient condition to set the timeline. Surviving a 5.6 hemoglobin crash requires a physician to flawlessly process the raw lab data and the physical reality of the human being in front of them at the exact same time. Looking first at the CBC report branch, we find a critical diagnostic tool, the MCV. MCV stands for mean corpuscular volume, which is simply a microscopic measurement of the physical size of an individual red blood cell. If the lab report shows an MCV reading below 80, it means the blood cells are physically stunted and abnormally small. In medical terms, these are microcytic cells. Seeing them immediately narrows the suspect list to two highly probable causes: a severe lack of iron or thalassemia, which is an inherited blood disorder that limits hemoglobin production. Conversely, an MCV reading over 100 reveals abnormally large, cumbersome cells. This entirely rules out iron issues and points directly toward a deficiency in vitamin B12 or folate. The MCV measurement provides a highly accurate shortlist of suspects based purely on the physical dimensions of the cells. But to secure a definitive diagnosis, the doctor needs to look at the next line of the report. This distribution curve maps out the RDW, or red cell distribution width. Instead of calculating the average size of the cells, the RDW measures the level of chaotic variation between them, tracking how many tiny, normal, and massive cells are floating around together. When you cross-reference a highly erratic RDW with a severely low hemoglobin level of exactly 5.6, a very specific biological pattern emerges. That specific mathematical intersection gives a physician a 95% certainty of iron deficiency anemia. The variation is so high because the body is desperate. It is so starved for iron that the bone marrow struggles to manufacture uniform cells, throwing out whatever irregular, poorly formed blood cells it can manage to keep the organs alive. The microscopic data perfectly explains what went wrong, but a piece of paper cannot tell a doctor how fast the patient's heart beats or whether they have minutes left to administer the cure. To make the actual treatment decision, the physician must drop the lab report and look directly at the physical human being sitting in the clinic. Moving to the patient condition branch of our triage matrix, we hit the first scenario: a patient with a 5.6 hemoglobin level, but whose breathing is normal and whose heart rate is completely stable. Oral tablets still act too slowly to be useful here. The protocol requires an immediate, direct infusion of liquid iron straight into the bloodstream. This infographic shows the exact clinical dosage required for this state: 200 milligrams of iron sucrose, dissolved into 200 milliliters of normal saline. Normal saline is a standard, sterile saltwater solution used to safely deliver intravenous medication. This specific IV drip must be administered carefully over a strict 45-minute window. The physician only has the luxury of taking those 45 minutes because the patient's vital signs are holding steady. When the physical body is calm, the medical team can safely focus all their efforts on aggressively replenishing the iron deficiency the lab report identified. But if the patient is breathless or exhibiting tachycardia, a dangerously rapid, erratic heartbeat, the rules completely change. In this unstable scenario, hooking up an IV and waiting 45 minutes for iron sucrose to circulate is a fatal error. The protocol here is non-negotiable. The physician must admit them instantly for a PRBC transfusion. PRBC stands for packed red blood cells, which is a highly concentrated dose of donor blood. The patient's heart is actively failing because it is pumping trying to find oxygen that simply isn't there. Giving the body raw iron to build new cells takes too long. The heart requires an immediate injection of ready-made, fully formed red blood cells to avert total collapse. The lab numbers dictate the diagnosis. But clinical triage dictates that a doctor must never treat a piece of paper. They must only ever treat the living patient in front of them.